Alright, welcome to dermatology today. I'm going to do this lecture recording today because I am not in Florida. So today we're going to talk about vesicular and bullous diseases. I apologize if it sounds like I have a little bit of a cold. My nose is a little stuffed up right now, and I also apologize if I'm breathing into the microphone. I'll try not to do that. I'll try to get it away from my mouth, so I'm not breathing right into the microphone. But here we go. Today we're going to talk about, like I said, vesicular and bullous conditions or diseases. Remember that these are primary diseases or primary lesions of the skin. Particularly, we'll see vesicles and bulla or bullae. With this, some are pretty common and some are rare, but you know that even though they are rare, we'll probably see them anyway on national boards. Pemphigus vulgaris is usually on national boards. I don't think we've seen dermatitis herpetiformis a lot on national boards before, but who knows, it may come on national boards pretty soon. But this is these are the conditions we're going to briefly talk about today. Is dermatitis herpetiformis, which is specific to gluten allergy, Pemphigus vulgaris, and its very similar cousin Pemphigus foliaceus. And then we'll see what's the difference between those two and bullous pemphigoid. Similar, but still there are some differences with that we'll try and get the specifics with. So dermatitis herpetiformis is text will say it's a rare chronic, intensely pruritic vesicular and bullous dermatitis or dermatosis. It's not very rare as in the other conditions that we're going to talk about, but sometimes it is a manifestation or a presentation of a gluten allergy, and so we can have a gluten sensitive or associated enteropathic disease here, but the main presentation to this is we'll have vesicles and papules, and it's going to be very, very pruritic. These can be usually on the extremities, so we'll see them in the elbows and the knees. Sometimes the sacrum, although that's not as common, maybe a little bit more common than the sacrum is the base of the scalp. Notice that this is where we usually see psoriasis, as we usually see it on the extensor side of the extremities, the knees, the elbows, and also the base of the scalp. So is there a connection there? There probably is, because it's the same kind of eczematic condition, or possibly a subclinical level of a Th1 condition. So I'm going to move the microphone here just a second. Here we go. So hopefully you can still hear me. Dermatitis herpetiformis is usually we'll see these intact vesicles. We'll see on the pictures that they also look like papules. They're not the huge formed vesicles that we are normally used to. And they can be difficult to identify. There's a certain pattern that I'll show you that is usually associated with herpetiformis pattern. And again, papules are going to be present. Urticaria, the last part of the course we'll talk about urticaria and hives. It's going to be confused with that, but it's going to have that raised lesions of urticaria. And sometimes the gastrointestinal involvement is going to be asymptomatic. We all know that. We've talked about that before, how a lot of times, especially with chronic gluten allergies or gluten sensitivities, there's no GI symptoms at all. We may have symptoms of the thyroid, symptoms of the maybe the adrenal glands, but it has, in some way moved on from the GI tract. But we may see some blunting of the intestinal villi. We may see that there is, with a biopsy, we may see that there's no formed villi, or sometimes with the biopsy we don't see anything. We don't see any kind of change with the form of the intestine, but we still see some subclinical autoimmune immunogenic reaction from wheat. And whenever we have a gluten allergy or sensitivity with this, we could have a risk of small bowel lymphoma, and so it's best to try and limit or decrease that immune reaction if we could. And like I said before, the thyroid disorders may be associated also. A lot of times with people with gluten allergies, there may be a Hashimoto's disease here. There may be a even in Graves' disease also. So in the laboratory, what can we order? A skin biopsy may show neutrophils and eosinophils. Well, we know with the gluten allergies or any kind of food, chemical, or mold sensitivities that usually eosinophils are going to be increased. We can test for an anti-gliadin or anti-transglutaminase with a serum or blood testing also. It's always going to be the case, although now it's known that there's other proteins than just the regular gliadin or standard gliadin that is being tested. And so we want to make sure that we're testing all of the gliadin specific antibodies. And what could this be confused with also? Well, it could be confused with insect bites, especially I found here in Florida there can be massive insect bites, flies, ants also. It can kind of look like, and even with insect bites, vesicles and bullae can actually be formed with this. And so we want to try and differentiate that. Again, get a good history, and also usually insect bites are going to be shorter lived than this dermatitis herpetiformis. Scabies and other insect bites, again, usually with scabies, we'll have this linear special lesion of the skin called burrows. So we want to inspect around that area to see if there's any kind of linear lesions. And then any kind of other eczema lesions, again, it may be more of a comorbidity than really anything else. So what's the treatment for this? Well, just basically we want to put these people on, and hopefully a lot of people on a gluten-free diet. There's also a medication called Dapsone that helps decrease the immune dysfunction that's associated with dermatitis herpetiformis, although it does alter the levels of the glucose 6 dehydrogenase. So we want to monitor CBCs if we're going to use that. Hopefully we're not. It's been seen in the literature that also nicotinamide, using that, has decreased the effects of Dapsone also. But hopefully just getting them off of gluten and then supporting that with maybe some liver supplements, liver detoxification, amino acids, essential fatty acids, will help to decrease the reaction. And this is what dermatitis herpetiformis looks like. So first of all, we can see the basic primary lesions here, the vesicles that are formed here. We can also see vesicles down here and here. I wanted to point out also here at the knee, the thigh and the knee here, there's actually a pattern that is formed here, kind of the grouping of papules and maybe vesicles around here. And this is really the herpetiformis form of pattern here, when there's a little bit of a kind of a star here and a star here, or a grouping of these papules. That's really what herpetiformis really means. We can see another herpetiformis grouping of vesicles here. And here we can see that maybe the differential diagnosis could be possibly herpes zoster reaction here, or because it is on the scalp, it could be psoriasis also. It's kind of a reddening psoriasis. It's going to have the same presentation again as psoriasis on the scalp and on the extensors, as we can see here. Extensor, 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 extensor. So a more rare, less common condition from dermatitis herpetiformis is pemphigus vulgaris. Again, this usually shows up on the national board, so it'd be a good idea to know some of the presentation, some of the pathophysiology of pemphigus vulgaris. And again, this is a very rare but potentially fatal autoimmune reaction that causes these vesicles and bullae to actually form on the skin, and actually separates the layers of the skin because of the autoimmune reaction. Average age of this is about 60. There is a predisposition to Ashkenazi Jewish descent individuals. Sometimes we can see oral erosions before the actual skin blisters and vesicles actually form. Another difference in presentation with this and dermatitis herpetiformis is the minimal itching. There's not that itching or pruritic characteristics of this that we actually see with herpetiformis dermatitis. Remember that with pemphigus vulgaris, the bullae are going to rupture easily, and so if we put a little bit of pressure on these vesicles or these blisters, there will probably burst. But there is a sign called Nikolsky's sign, that if we try and maybe put pressure on the bullae or the blister and it doesn't burst, sometimes it'll actually make a larger blister or bullae by actually putting pressure on some of these blisters. And we'll see a kind of an illustration of that here. The healed erosions can cause brown pigmentations as kind of a scar tissue, or hyperpigmentation after they've actually healed, and the blisters and erosions may also appear in the internal viscera, including the pharynx and the esophagus. We can do lab testing. It's a little bit more of an advanced testing of immunoglobulin G and complement C3. Remember, with any kind of autoimmune reaction or subclinical autoimmune reaction, it'd be a good idea to run the ELISA Act testing for sensitivities, and that may be also true with pemphigus vulgaris. But also we can run antibodies to demsogline 3 and antibodies to keratinocyte adhesions. What that's going to do is show that there's actually an immune reaction fighting and separating these kind of tight junctions of the skin, and actually causing a reaction of the blisters, the vesicles, and the bullae here. So here we see pictures of pemphigus vulgaris where the blisters are not formed. They're usually very, very fragile, so we don't really see a lot of blisters on these individuals. Like, I don't really see a lot of blisters here. These lesions are usually deeper lesions than the other ones that we're going to show you from the other conditions. So we see very much an ulceration with a lot of these lesions here. And then on the bottom here, this is the Nikolsky sign. We're actually putting pressure on the blister, and it's actually spreading to make a larger blister. And so let's move on to the third condition here, the pemphigus foliaceus. This is also an autoimmune reaction. These are all kind of autoimmune reactions of some severity. We'll still have the blistering disease. We'll still have the crusted patches, but usually with Pentaphygus foliceus we'll have more of a superficial appearance than these lesions. And so this is Pentaphygus vulgaris with very deep, it's very vulgar, it's very deep lesions. So Pentaphygus foliceus, if you remember foliceus being maybe hair follicles, it's more superficial. We're not going to see the deep, very very harsh, severe reaction that we did with vulgaris. We usually will see this more of a designated or confined area of the face, scalp, chest, and upper back. We're not going to see it, like we did with vulgaris here. We're not going to see it all over the body. And so it's still will have very fragile blisters. You won't see a lot of blisters. And we'll see some crusting, as we said before. And again, we can order some of the same testing, the desbigline 1, those type junctions of the skin. We can also order a seropositive, or we can order an ANA, which is going to be seropositive, but like a lot of autoimmune reactions, that ANA is going to be positive anyway. The main diagnosis that we're going to have with positive ANA is going to be, lupus. So again, it's going to look kind of like vulgaris, but not as severe. Because of the crusting, we may think it's going to be a little bit like a bacterial infection, like impetigo. Seborrheic dermatitis maybe could be in the same area, but again, it may look actually a little bit more severe than seborrheic dermatitis also. It's going to look like a really, really bad sunburn. So here we go. So we see the superficial erosion here. We see maybe some crusting, especially in here into the chest. We see a lot of crusting with this. But again, this is post formation of the blisters here, and again we also see it into the back here. Hopefully you can hear me okay. So the back, the face, the scalp, the chest, and the back. So Pentaphygus foliceus. So this is not as severe, a little bit more nice looking. If we compare this with, this, very severe, very deep, very vulgar, very foliceous, very superficial, not as rude. So that's how I remember it. And last but not least, bullous pentaphygoid. This is also very uncommon, rare autoimmune blistering disease. Primarily affects the elderly. Also has autoantibodies to the proteins that actually make up the junctions of the skin layers, but these proteins are a little bit deeper in the skin layers, and so we can think about that as being one of the characteristics of bullous pentaphygoid. And because one of the characteristics is that the blisters are actually not fragile, they actually will stay on the skin, and so they're not going to break very easily with this. This can be triggered or caused by certain reactions of medications. It usually is maybe on the skin folds, although the pictures that I'm going to show you are not really on the skin folds. What else can I tell you here? They can be pruritic, like hives or urticaria, form papules like dermatitis herpetiformis. Itching can be moderate to severe, so it's going to be more like the herpetiformis dermatitis. And the bullae, this is the big difference between foliceus and vulgaris, is bullous pentaphygoid is going to be of good structure and integrity, and so the bullae are going to be still formed, and they do not spread like vulgaris. So let's take a look. Actually, what we can do, again, the laboratory is going to be the same as the other two. The differential diagnosis is going to look a little bit more like vulgaris because it's going to have more of an appearance of an acute appearance, a more of a deeper appearance with this. And so it's going to be more of the differential. And then dermatitis herpetiformis, because of the vesicles, the papules are going to be present, and the itching, that's going to be present also. Plus it favors the extensors, just like herpetiformis. And we'll see that here in a second. So here are the formed blisters, and so if we show you pictures of formed blisters, that is a vesicular and bullous condition. It's probably going to be, bullous pinophagoid. You can see the formed blisters here. After they heal, they may have a hyperpigmentation because of scar tissue with this, and because it's kind of a deeper lesion than the others that we see. Here we see a very acute condition here. This would be more of an emergency condition that we see here. Again, this is very rare, not as common. I didn't really show you a lot of skin folds. Maybe right here in the skin fold a blister is forming, so I didn't really find a lot of good pictures on it actually congregating within skin folds. Maybe within the armpit. Where's my arrow here? There it is. Maybe within the armpit here have some skin folds. So but that's about it. Let me see that. Let me go back. So this is just in review. Bullous pinophagoid. We have the formed blisters, formed bullae, some vesicles, very itchy, very pruritic. Sorry, text. This is the Pinophagus foliceus. Superficial. Doesn't look as severe as vulgaris. Not as pruritic, not as deep. So if we go into Pinophagus vulgaris here, we have more of a widespread lesions, which the Pinophagus foliceus is usually confined to the chest, the back, the scalp of the head. This is more widespread, as you can see in the body. Again, both of those, the blisters are not, or the blisters are very fragile, so we put pressure on them, they are going to burst, and sometimes we don't even see the presentation of blisters with this. It's just open sores and crusting. And then last but not least is the dermatitis herpetiformis. Again, the herpetiformis form is around here, kind of the grouping of the papules, very itchy, very pruritic. We can see presentation of vesicles also sometimes with this, usually in a circular. Here's a linear, which is kind of weird. And then we kind of differentiate that with psoriasis or herpes zoster, usually on the extensor side. Again, scalp, elbow, knee. This looks like the scapula maybe, which is kind of a weird presentation. Maybe I'm wrong about that. But there you go. Review of those. I'll put a link for this presentation on Signet. The slides are already on Signet. And any questions, please email me or come see me. And I'll be back next week. Thank you.